So you take about 20,000 breaths every single day. I mean, if you pause right now and just take a slow inhale, you can actually feel the mechanics of it. Your diaphragm pulls down, your ribs expand, and, negative pressure just draws air deep into your
Yeah,
chest.
20,000 times a day. It's wild.
Right. Your body performs this really complex mechanical expansion constantly. And unless you're like meditating or you just finished a sprint, you probably don't think about a single one of them. But the second just one of those breaths goes wrong, suddenly it is the most important thing in the world.
Oh, absolutely. It completely takes over your reality. I mean, that automatic invisible rhythm that we just completely take for granted is suddenly front and center. Everything else in your life just sort of fades into the background when you can't pull in enough oxygen.
Exactly. And when that happens, you usually end up in a clinic or a hospital, and a medical professional starts asking you all these questions. So today, we are taking a deep dive into the clinical practice guidelines for nurses in primary care. Specifically, we're looking at the 2010 edition from the First Nations and Inuit Health Branch.
Yeah, and we're focusing entirely on their really comprehensive section on the respiratory system.
Right. Our mission today is to demystify how these primary care nurses act as basically respiratory detectives. We're going to decode the seemingly strange, honestly highly specific questions they ask you to figure out exactly what is happening inside your chest.
It's a great way to frame it.
Yeah. And by the end of this deep dive, you're going to have a whole new appreciation for your own internal machinery.
You know, the word detective is incredibly appropriate here. When you present with a breathing issue, a primary care nurse isn't simply looking at your lungs in isolation.
Hmm.
They are, they're really mapping out your anatomy through conversation.
Wow, mapping it out just by talking.
Exactly. The guidelines lay out an approach based on gathering clues around cardinal symptoms. So things like the specific nature of a cough, the color and volume of sputum, the exact triggers for your shortness of breath, and the characteristics of any chest pain.
Okay, let's unpack this because the way they investigate these symptoms is honestly fascinating. Let's say you come into a clinic complaining of chest pain. The nurse doesn't just ask if it hurts. They need to figure out if the pain is pleuritic or non-pleuritic.
Right, which is a huge distinction.
Huge. And if you're wondering what that means, your lungs are wrapped in this double-layered membrane called the pleura.
Yeah, so think of the pleura like two sheets of smooth silk, and they're just gliding over each other every time your lungs expand and contract. But if you have an infection like pneumonia or some kind of injury, those silk sheets become inflamed.
So they lose all that smooth lubrication.
Exactly. Suddenly they rub together like coarse sandpaper.
Oh, man. That sounds agonizing.
It really is. That sandpaper friction causes a sharp stabbing pain every single time you take a breath in. And that is what we call pleuritic chest pain.
Okay, so if you describe that specific feeling, the nurse immediately knows the issue is likely right there within the lung tissue or that surrounding membrane.
You got it.
Yeah.
Non-pleuritic pain, on the other hand, is usually this constant heavy ache that doesn't really change when you breathe in or out. And that points the nurse in a totally different direction, away from the lungs and toward, diseases of the pulmonary vessels or maybe the aorta.
It's just wild how specific it gets. And the line of questioning gets even more granular when they try to measure a patient's shortness of breath, because instead of just asking like, hey, how hard is it to breathe? They ask for these functional metrics.
Right, they need measurable data.
Yeah. So they'll ask, how many stairs can you climb before you have to stop? Or, honestly, my personal favorite, they ask the pillow question. They want to know exactly how many pillows you use to prop yourself up when you sleep at night.
It's such a classic question.
Right. But think about it from the patient's perspective. To someone sitting on an exam table just desperately trying to catch their breath, interrogating them about their bedding has to sound completely bizarre. Like, I'm kind of comparing the diagnostic process to a mechanic troubleshooting a car here. Why are they asking about your bedroom habits when your engine is sputtering?
Well, what's fascinating here is that the pillow question is actually a highly specific clinical metric for a condition called orthopnea.
Orthopnea, okay.
Yeah, orthopnea is shortness of breath that is triggered entirely by lying flat. And the mechanics of this are all about gravity. So when you are standing or sitting up during the day, gravity pulls the fluids in your body down, causing them to pool in your lower extremities, like your legs and your ankles.
Okay, that makes sense.
But the moment you lie down flat in bed, gravity is neutralized. So all that pooled fluid shifts right back into your central circulation.
Wait, so all that liquid is suddenly rushing back toward the core of your body?
Exactly. Now, if your heart and lungs are healthy, Your body just, pumps that extra fluid volume through the system without any issue. But if your heart is failing, specifically we're talking about congestive heart failure, it simply can't handle the sudden influx of fluid.
Oh, wow.
It pumps sluggishly, and that fluid literally begins to back up into the lungs. So by asking how many pillows you use to sleep, the nurse is gauging exactly how steep of a physical angle your body requires just to keep that fluid from drowning your airways.
That is incredible. So 3 pillows means your heart is struggling significantly more than someone who only needs 1 pillow.
Precisely. They are assessing the interconnectedness of your cardiovascular system just by asking how you sleep.
I mean, gravity is literally doing the diagnostic work for them there. And the guidelines mention another nocturnal condition they screen for that sounds genuinely terrifying. It's called paroxysmal nocturnal dyspnea, or PND.
Yeah, PND is incredibly scary for the patient.
I can imagine. This is a scenario where you wake up out of a dead sleep, acutely short of breath, just gasping for air. And what really stood out to me in the text is that it takes 20 to 30 minutes of sitting upright for the attack to resolve. Why does it take so long?
Well, that delayed recovery is a massive clinical clue. When you wake up gasping, you intuitively sit up on the edge of the bed, right? But the fluid that is already flooding your pulmonary space doesn't just instantly vanish.
Right, because the fluid is physically already in the lungs.
Exactly. Your compromised cardiovascular system has to slowly, mechanically pump that redistributed fluid out of your lungs and push it back down into the lower body. And that sluggish physiological clearing process, it just takes about 20 to 30 minutes.
Wow.
If the issue was just a simple momentary airway spasm, it would resolve much, much faster.
Okay, so that fluid pooling over time obviously leads to a lot of wear and tear.
Yeah.
And that gradual structural breakdown naturally points us toward the most common long-term respiratory issues.
The chronic conditions, yes.
Yeah, the guidelines focus really heavily on the big 2 chronic culprits, asthma and chronic obstructive pulmonary disease, or COPD. And, while they might both cause you to wheeze, mechanically, they are entirely different beasts.
They're very different.
Because asthma is characterized by variable airflow limitation and airway hyperresponsiveness. Basically, your airways get inflamed, they swell up, and they just clamp down.
Right. Asthma is fundamentally an overreaction to stimuli. But the key feature to remember is that it is generally reversible. The actual structure of the lung isn't permanently destroyed.
Yeah.
The airways are just hypervigilant.
Just constantly on edge.
Yeah, and those triggers can be the usual suspects we're all familiar with. Things like cold winter air, heavy exercise, or, pet dander.
But here's where it gets really interesting. The guidelines list some asthma triggers that completely caught me off guard. Dietary sulfites. I mean, you can trigger an asthma attack by snacking on dried fruit or just drinking a glass of beer or wine.
I know, it sounds bizarre, but the mechanism behind that is actually quite chemical. Sulfites are used heavily as preservatives, so when they hit your stomach acid, they release a tiny amount of sulfur dioxide gas.
Wait, gas inside your stomach?
Yeah, and that gas wafts right back up the esophagus, hits the airways, and irritates the incredibly sensitive neuroreceptors there. So in an asthmatic patient, those receptors panic and signal the airways to violently constrict.
That is wild. The text also mentions medications that seem totally unrelated to the lungs, like aspirin, which they refer to as ASA in the text, or even beta blockers prescribed for heart conditions. These can set off non-allergic asthma.
Yeah, absolutely can.
It's like having asthma is essentially like living in a house with a highly sensitive, totally glitchy security system. The alarm blares and the steel blast doors shut down just because, a single leaf blew across the front porch.
That's a really good analogy. The system is trying to protect you, but the overreaction is actually what causes the harm. During an attack, those blast doors closing means the airways narrow significantly. Mm-hmm. And as you try to force air through those tiny restricted tubes, it creates that classic high-pitched wheezing sound.
Right, that sound everyone associates with asthma.
Exactly.
Mm-hmm.
But if we connect this to the bigger picture, there is a clinical presentation the guidelines warn nurses about that challenges everything we naturally assume about symptoms. It's called the silent chest.
Okay, yeah. If you are listening to this right now, just imagine your chest feels super tight, you are struggling for air, and you finally make it to the clinic. The nurse listens to your chest with a stethoscope, and there is no wheezing. There's just total silence.
Right, and a layperson might think, oh, there's no wheezing, the attack must be subsiding, they're getting better.
But they're not.
Not at all. The silent chest means the airway restriction is so severe that there is simply not enough air moving into the lungs to even generate a sound. The absence of the loud symptom is actually a sign of catastrophic, impending respiratory failure.
Oh my God.
It is status asthmaticus, which is the most dangerous form of asthma. The silence is the ultimate alarm.
That is terrifying.
Uh-huh.
Okay, so contrast that hyperreactive, glitchy security system of asthma with COPD. If asthma is the alarm system acting up, COPD is like the gradual crumbling of the house's foundation itself.
Very much so.
The guidelines describe COPD as a progressive airflow obstruction coupled with the actual permanent destruction of lung tissue.
Yeah, and within COPD, the guidelines detail two predominant patterns of destruction. First, you have chronic bronchitis.
Yeah.
And the clinical definition here is really specific. A patient must have a chronic productive cough for at least 3 months a year for 2 consecutive years.
So they're just constantly coughing stuff up.
Exactly. The internal lining of their airways is constantly inflamed, producing heavy, thick sputum. Then on the other hand, you have emphysema. In emphysema, the cough is actually minor, but the main symptom is chronic, relentless shortness of breath.
Because the structure is failing.
Right. The tiny air sacs in the lungs, the alveoli, lose their elasticity. Think of an old, stretched-out rubber band that just won't snap back anymore. The lungs become floppy, and they can't push the stale air out, which leaves no room for fresh oxygen to come in.
And the drug therapy for this is really complex, right? You've got inhalers, bronchodilators, steroids, but one of the key non-pharmacologic interventions the guidelines recommend is surprisingly simple: hydration.
Yes, hydration is critical.
The text stresses drinking 6 to 8 glasses of fluid a day. Not more, because there is no evidence that excessive water helps, but just enough to keep the system lubricated.
The mechanics of that are essential. Your airways are lined with these tiny hair-like structures called cilia, and their job is to constantly sweep mucus up and out of your lungs.
Like little brooms. Like little brooms, exactly. But in COPD, that mucus becomes incredibly thick and sticky. If you're dehydrated, that mucus literally turns into glue, trapping bacteria inside the lungs. Drinking enough water thins the secretions out, changing the viscosity so those tiny cilia can actually sweep the garbage out of the respiratory tract.
Which means we are dealing with a system that is just intimately connected to the outside world. I mean, every single breath is an interaction with the environment. And that constant exposure makes the respiratory tract incredibly vulnerable to microscopic invaders.
It's a constant battleground.
It really is. So let's look at the battleground of infections, bronchitis versus pneumonia. It is so easy to get these two confused in everyday conversation, but anatomically they happen in completely different territories.
They do.
Bronchitis is an inflammation of the larger airways, so the windpipe or trachea and the major bronchial tubes branching off it. Pneumonia is an infection much deeper down, right? Flooding the tiny distal airways and those delicate air sacs we mentioned earlier. And that anatomical location entirely dictates both the severity of the illness and the treatment approach. The guidelines are adamant about acute bronchitis. 90% of acute bronchitis cases are viral. We are talking about things like influenza, rhinovirus, or RSV, respiratory syncytial virus.
Okay, I have to step in here and play the role of the frustrated patient for a second.
Laugh for it.
If I have been coughing up nasty green sputum for a week, my chest is burning and I feel absolutely terrible, my instinct is to march into that clinic and demand a pill. I want an antibiotic to fix it. Why is the nurse just telling me to go home, drink tea, and rest?
Well, this raises an important question about antibiotic stewardship. And honestly, primary care nurses spend a lot of time educating patients on this exact frustration. Antibiotics are highly specialized weapons designed to destroy the cellular walls of bacteria.
Okay.
But viruses, like the ones that cause 90% of bronchitis cases, do not have cellular walls. They are essentially just floating packets of genetic code that hijack our own cells.
So prescribing an antibiotic for a viral infection is basically like trying to unlock a smartphone with a physical brass house key.
That is the perfect way to visualize it. There is no physical lock for the key to fit into. The antibiotic just floats through your system, finding nothing to attack, completely ignoring the virus.
And doing collateral damage along the way.
Exactly. Meanwhile, it wipes out the healthy bacteria in your gut and contributes to global antibiotic resistance. So the guidelines explicitly mandate that for acute bronchitis, routine antibiotic treatment is not recommended. The nurse just has to educate the patient that the cough is a natural clearing mechanism and it might persist for 2 or more weeks.
So it's just a large airway annoyance and you just have to write it out.
Unfortunately, yes.
But pneumonia is a different beast entirely. It's that deep, small airway flying. The guidelines break down the causes, often bacterial, like Streptococcus pneumonia, which is where antibiotics are absolutely necessary. But what really jumped out at me in the guidelines is how pneumonia presents in the elderly.
Yeah, this is a vital clinical pearl that absolutely saves lives. Because in a younger, otherwise healthy adult, pneumonia looks exactly like a textbook says it should. A high fever, sharp localized pleuritic chest pain, and coughing up yellow or green sputum.
Right, because their robust immune system goes to war, creating massive inflammation and heat.
Exactly. But in elderly clients, the immune system experiences a natural decline called immunosenescence.
Right, so they don't mount that massive fiery response. The guidelines state they might not cough at all, and their temperature might be completely normal. Instead, they present with sudden confusion, a complete loss of energy, or even vomiting.
It's so deceptive. Their lungs are still filling with fluid, but because the immune alarm bells aren't ringing, the most prominent symptom becomes hypoxia, a lack of oxygen to the brain.
Oh, wow.
And that brain starvation is what causes the sudden confusion. The pneumonia is silently masquerading as cognitive decline or just a sudden stomach bug. So a perceptive nurse has to look past the obvious, realizing that confusion in an elderly patient might actually be a suffocating lung.
That is just incredible. Okay, so we've talked about chronic structural damage that takes years, and we've talked about microscopic viral invaders that take days to brew. But sometimes respiratory failure happens violently and in seconds.
The immediate threats.
Exactly. The emergencies where primary care nurses have to act instantly to maintain the ABCs: airway, breathing, circulation.
Right. And in these high-stakes scenarios, mechanical intervention is really the only thing standing between the patient and death. One of the most dramatic emergencies detailed in the guidelines is the tension pneumothorax.
Let's explain the mechanics of this because it sounds like a horror movie. A simple pneumothorax is a collapsed lung, usually from a tear or a trauma. But a tension pneumothorax acts like a one-way biological valve. Air leaks from the damaged lung into the pleural space, that cavity around the lung we talked about during inhalation.
Right.
But when the patient exhales, the tissue flap closes and the air is trapped.
And so the pressure builds exponentially with every single breath. It completely crushes the collapsed lung flat against the spine. And as more air gets pumped into the chest cavity, it literally starts pushing the mediastinum, which houses your heart and your major blood vessels, over to the opposite side of your chest.
And the pressure on the heart means it literally can't expand to pump blood, right?
Exactly. Your blood pressure plummets to lethal levels in moments. So the nurse's intervention here isn't a medication. It is immediate mechanical decompression. They have to find the mid-clavicular line, essentially drawing an imaginary line straight down from the middle of your collarbone.
Okay.
Then they locate the second intercostal space right between the ribs and insert a large 14-gauge hollow needle perpendicularly into the chest cavity.
And there is a crucial anatomical detail they must follow here.
Ah.
The needle has to go just over the top of the third rib. It
Yes.
absolutely cannot go under the rib.
Never under the rib.
Right, because the nerve bundles and blood vessels run tucked up under the bottom edge of every rib. If you hit those, you cause catastrophic bleeding and permanent nerve damage. But when they guide that hollow needle correctly over the top edge, the guidelines note the nurse will feel a physical pop through the membrane and hear a literal rush of pressurized air escaping.
It's amazing. You are manually venting the pressure chamber to let the heart beat again. It's pure mechanics. Another mechanical emergency that requires a surprisingly counterintuitive approach is acute foreign body obstruction, choking.
Okay, so what does this all mean for us? Because, I mean, we've all been in a restaurant or at a dinner party where someone starts choking and coughing violently, and the immediate panicky instinct is to jump out of your chair, run up behind them, and start delivering abdominal thrusts.
Right, the Heimlich.
Yeah. But the guidelines are incredibly strict. Absolutely do not do that.
The distinction a nurse, or honestly anyone must make, is between a partial and a complete airway obstruction. If the patient has a partial obstruction but can still cough forcefully, if they can talk or pull in a breath, you do not intervene physically.
You just let them be.
You allow them to clear their own airway with spontaneous coughing.
Because doing abdominal thrusts on a coughing person is it's like trying to fix a jammed office printer while the internal rollers are still grinding to push the paper out.
That's a perfect way to look at it.
Right. Taking the machine apart or yanking the paper just voids the warranty and rips the sheet, making it so much worse.
Taking that step further, if you forcefully compress the abdomen of someone who has a partial blockage, the sudden pressure spike can actually wedge the foreign object deeper into the vocal cords. You can turn a totally survivable partial obstruction into a lethal complete obstruction.
Oh, wow. I never thought about that.
Yeah, you only intervene with thrust when the coughing stops, they cannot speak, and they show the universal sign of clutching the throat.
So basically, let the machine clear its own jam until it can't.
Exactly.
Okay, the final emergency the guidelines highlight is incredibly deceptive: inhalation of toxic materials, specifically carbon monoxide poisoning. Carbon monoxide is the silent killer leaking from a faulty furnace or car exhaust. And what's wild is how the physical body looks when it is being poisoned by it. You would think someone suffocating from toxic gas would look blue or pale or gray,
You think so, yes.
but the guidelines note that carbon monoxide poisoning causes a flushed face and rosy red cheeks. They look vibrantly healthy.
The physical deception is dangerous, but the technological deception is actually much worse. The guidelines specifically warn nurses that pulse oximetry, that little glowing clip they put on your finger to measure blood oxygen, is entirely inaccurate during carbon monoxide poisoning.
Wait, the machine literally lies to the medical professional.
It does. That is because a pulse oximeter uses light waves to measure how saturated the hemoglobin in your blood is.
Oh.
It basically just checks to see if the seats in the car are full. But it cannot differentiate between oxygen and carbon monoxide. And carbon monoxide binds to your hemoglobin roughly 200 times more powerfully than oxygen does. It essentially kicks oxygen out of the car and locks the doors.
So the machine reads 100% saturation because the hemoglobin is totally full and the patient has rosy red cheeks, but their brain and their organs are actively starving to death.
Precisely. It perfectly illustrates why human clinical observation, taking a history, knowing the patient was found near a running engine or a fire, just seeing the whole picture is paramount. You can never blindly trust the machines.
Man, this entire journey through these guidelines really proves how resilient and complex the human body is, and just how demanding the job of a primary care nurse really is. We started with the detective work of decoding the angle of your sleep and the specifics of a cough. We moved through the gradual crumbling of the lungs in COPD and the hyperreactive alarms of asthma.
We covered a lot of ground.
We did. We explored the microscopic wars of viruses versus bacteria, and finally, those violent mechanical emergencies where just a hollow needle and a rush of air can save a life.
It is a profound, continuous mechanical and chemical dance happening inside your chest every single second of every single day.
It really is. So the next time you take a deep breath, or the next time a nurse asks you exactly how many pillows you need to fall asleep, you will know exactly why. They are reading the invisible machinery keeping you alive. But here's a final thought to leave you with. These guidelines we explored today, they were published by the Health Branch back in 2010.
That's right, over a decade ago.
Right. Think about how much the air we breathe has changed since then. With the rapid rise in new environmental challenges, we are talking about the massive increase in global wildfires filling the sky with particulate smoke every summer, or the modern explosion of vaping and the daily inhalation of synthetic chemical aerosols. How much more complex is the job of the respiratory detective going to become, just to protect our invisible, constant need for oxygen? It's a great question. The environment is a moving target, and the very composition of the air we rely on is evolving.
Definitely something for you to think about the next time you take one of your 20,000 breaths today. Until next time.